So the genesis of this conference has been influenced obviously by COVID. It's nice to have so many people who are able to join us this way, and we're hoping to see you, at least some of you, in face-to-face in Oxford in 2022, next year, April the 4th to the 6th, for a face-to-face, largely face-to-face conference. I need to say, to state something fairly obvious, but it needs stating, and that is that there will be at this discussion, at this conference, discussion of ketamine for psychiatric disorders, and ketamine is not a licensed treatment for psychiatric disorders. Carla will be talking about S-Ketamine nasal spray, which is a licensed treatment for some indications. So without further ado, what I'd like to do is just introduce Jerry Sanacora, who's been a great friend of this enterprise. He's on the steering committee of this conference, and he is the George and S. DeGrosse Professor of Psychiatry and Director of the Yale Depression Research Program and co-director of the Yale New Haven Hospital Interventional Psychiatry Service, which includes use, I think, of IV ketamine and as well as other neurostimulatory interventions. And he's going to guide us through the neurobiological mechanisms believed to contribute to the rapid antidepressant effects of ketamine, and to discuss the prospects for the next generation of rapid acting antidepressants. So, Jerry, over to you.
Thank you very much, Rupert. Thank you, Sarah. I'm really very happy to participate in this. It's a great meeting. I know you've done a lot for this. My only regret is that we couldn't be there in person. So I'm hoping today I'd like to kind of bring you up to date on where things have gone with our understanding of the neurobiology of ketamine treatments. But I want to do it in a way of presenting a timeline of kind of giving the history and bringing us up to date. It's impossible for me to cover every possible part of the neurobiology. I know we have breakout sessions where hopefully we get a chance to talk about that. I'm going to try to do it in a more cohesive narrative way, but hopefully I'll touch on most things, and those that we don't, we can talk about later. Would like to just move forward and, whoops, why is it not advancing for me? There we go. I do have several disclosures, so please note that. And if anybody has any questions, I'd be more than glad to talk about that. And Rupert, thank you for mentioning that I will be talking about ketamine here. And again, IV racemic ketamine is not, does not have a license or an indication by the FDA as a treatment. So if we can move to the next slide. So specifically what I'd like to do is to cover a few things. One, just really give a brief understanding is, why do we really care about the neurobiology of, it works, why do we care? But I'd like to, give a few reasons why we should care. And then to talk a little bit about the event setting the stage of the discovery of ketamine's antidepressant effects. And then really to do as much as I can to bring us up to date on what our current understanding is of the more basic neurobiological principles of its effects. And I'll touch a little bit on some of the other non-direct or proximal effects of the pharmacology. And then ultimately to outline sort of the key relevant questions that remain, including where's the next generation. So as I said, the first question is, why do we really need to understand the underlying mechanisms? And I'd like to say, for those of us who are attending this, or for those that are really clinicians and not scientists or not drug development people, why should we really worry so much about the mechanism? And I think it's important for several reasons, but the most being, we really need to understand and predict both the moderated and mediators, so we understand the risk and benefits of the treatment, and things like which medications can we or should we avoid giving with the treatment, or what should we try to combine with the treatment, ways of developing and optimizing ketamine response. Are there things that we can use adjunctively or concomitantly to amplify those effects? If we understand the mechanism, we may be able to optimize the efficiency. So do we really need to have these long infusions? Could we give very short periods? Could we dose more frequently? Can we dose more with a longer interval? I mean, these are all very important questions that we can learn from the mechanism. And then lastly, and I think very importantly, is ways of understanding how to develop the next generation of antidepressants. So if we just start briefly, the need is pretty obvious. The need for new antidepressants, despite the real benefits that our existing antidepressant treatments have brought over the past 50 years, depression still remains one of the leading causes of disability throughout the world. The rates of suicide, at least in the US, have actually been increasing over the past decades. And we know from the STAR-D, but many of these other more real world type studies, that there are real limitations to the effectiveness of our treatments, especially after you get beyond the standard 1 or 2 trials of antidepressants. But the fact that most of these all targeted the same mechanisms, it shouldn't be that surprising that if you don't respond to 1 or 2 of that class, the chances of the 3rd or 4th working are, greatly reduced. So all these are pretty obvious arguments. And the additional argument is the time it has required for these antidepressants to have real benefit. And this, again, from the STAR-D study, you can see even to the patients that ultimately do go on to have a good response, it's typically taking about 6 weeks for people to get to at least having half that improvement. So there's always been a real unmet need for having increased speed of onset. And in fact, if you go back just 20 years ago, this is Elliot Rickelson wrote, sort of that it's always been the holy grail in the field to have these rapid onset of antidepressant-like effects, but they just didn't exist. And 20 years ago, it was written as just a given that it's going to take a long time for antidepressants to work. And I think ketamine, possibly more than anything, has just changed that perspective. And it changed that perspective in the field that you could have rapid onset of effects, which has really had a big influence on the field and the future of the field. I think the next, the next is, why ketamine? Why did anybody really start using ketamine as an antidepressant? Well, it dates back quite a while. Now it dates back, going 60 years ago. George Crane, I'm not sure how many of you have seen this before, but noticed that when D-serine was being used as a treatment for tuberculosis, that their patients were having this very rapid onset of improvement, specifically in their mood, their sleep, their anorexia, their eating problems. These are people with tuberculosis being treated. And quote right out of his paper is, "It's difficult to explain why psychiatric benefits should have occurred almost immediately following drug administration." I mean, at the time, there was no idea that the seromycin that was being used had any, the D-serine had any effects on the glutamatergic system. In fact, at the time, glutamate wasn't even recognized as a neurotransmitter. But in retrospect, this may have been one of the original findings showing that a drug targeting the Nmda receptor of the glutamatergic neurotransmitter system could have these rapid onset of antidepressant effects. But really, it was the discovery of ketamine, which came from PCP, the work that was done at Park Davis Labs and others developing phencyclidine. And then a lot of credit goes to Ed Domino, who really took this and started to develop ketamine as an anesthetic, which it received its FDA approval in 1970. but really pushed us to understand the basic pharmacology and neurobiology much better. And that's when we started to realize that ketamine prominent effects, or it's probably its largest effects, definitely in producing some of its anesthetic properties, is by acting as a non-selective, non-competitive Nmda receptor antagonist. So, and with that, it entered into the world of psychiatry research. A lot of the original research was actually using ketamine as a model for psychosis, which in some indirect way was actually how we ended up using it for depression. I'll talk about that a little bit. But there were also studies that came out very early that I talk about it kind of dying on the branch. There were findings out there from very different perspectives. A study that came out of Tehran as early as 1973, where ketamine was used really as an assisted psychotherapy approach, and really looking at effects on abreaction, which I actually had to look up to see what that meant. I'm not a psychoanalytic psychotherapist, but it was really this release, this catharsis, the ability to have that. And they interestingly, after treating 100 patients, and in this paper, they weren't using DSM diagnoses at all. These were just 100 psychiatric patients in hospitals. They arrived at a dose of 0.5 mg per kg as being kind of the ideal dose, which was interesting, not a very scientific approach to dose finding, but still an interesting finding, but really reported these rapid onset of benefits in those patients. And then there was also identified through animal studies in these version of high throughput screens they had at the time of having antidepressant-like effects. And that goes back to 1974. So going pretty far back, there was some clue that ketamine may have antidepressant effects. But I have to say those studies and that data kind of died on the branch. It really, if you look at the history of it, it wasn't that these studies were what eventually evolved into our current use for the most part, and definitely wasn't the lineage that ended up with the FDA indication for S-Ketamine. What really was more in the direct line to that was some evidence that were occurring or being discovered around the turn of the millennia. So this is the time when Wayne Drevitz had some seminal work, and Doug Bremner, Vetcheline, showing that there were actually volumetric and structural changes associated with depression, areas like the subgenual prefrontal cortex, regions of the hippocampus, that were actually showing pretty dramatic changes. And other work coming out of Grajner-Raskowski's lab and others showing that there were cellular and cytoarchitectural changes, in large part changes in glial cell number and density that were occurring in patients with depression. And right around the same time, there was also a flurry of evidence coming out suggesting that the glutamatergic neurotransmitter system was likely to be a key player in this pathoetiology or pathophysiology, linking stress to major depressive disorder. So work from Bob Sapolsky's lab, Bruce McEwen's lab, really showing how stress could have these toxic effects and how that could be mediated through glutamatergic action. Work by Vita Mogadim's lab, and I'll show some other work from her lab, but using microdialysis, showing that stress can induce this rapid bolus release of glutamate, and other work better understanding how this could have toxic effects. All was coming out right around the turn of the millennium. We were starting to understand that the glutamatergic system may play a prominent role in this translation from stress to depression. With that, we also started to get a much better understanding of the pharmacology of glutamate, and it's an incredibly rich and complex pharmacology. And this is just a slide basically showing all the different areas that can be targeted pharmacologically with glutamate within the glutamatergic system. And NMDA receptors sit right in a key position to modulate NMDA, to modulate glutamate function. And having ketamine available was a great opportunity. Along with that, there were studies by Phil Skolnick's lab out at the NIH at the time, really starting to uncover the role of the Nmda receptor in the pathophysiology, especially the stress-related effects, but some of the initial work showing that antagonists of the Nmda receptor could actually have antidepressant-like effects in rodent models. So this was the data that was, available in the late 1990s when John Crystal, Dennis Charney, Rob Berman, and a few others at Yale really devised the first study specifically looking at treatment of depression with ketamine. And this is actually a quote from a paper that we wrote that actually taken right from John and Dennis giving some of this feedback, but as to what was their thinking behind doing that first study. And as captured here, John really would say that it was this change in perspective, this idea that initially the monoaminergic system sat at its hypothesis that if there are really problems within the monoaminergic system, these are really problems more centrally located within the pons and midbrain, and that the cortex is really sort of secondary to this, with all this other evidence coming out suggesting that there was more evidence of cortical or subgenual regions or hippocampal regions being involved, which are predominantly regulated by glutamatergic and GABAergic systems, that it would be wise to investigate whether targeting those systems could have antidepressant-like effects. And that was really what led them to that first study that was performed, where they did a simple 7 patients, or actually 8 patients data really from 7 in the long run, where it was randomized crossover study. I'm sure everybody's very familiar with this. 1 dose of ketamine, 1 dose of saline, and that was really where this rapid onset of antidepressant effect was discovered and where things took off from. And then the history of that would be that, and it's actually, here's the quote from John. I really, just to capture their surprise in this effect. This wasn't, when this study was done, it really wasn't done with the idea that they were going to give ketamine a single dose and you're going to get this rapid improvement. They were aware of the data from Phil Skolnick's lab. They were aware of the pathophysiology, but weren't really expecting this rapid response. So as John actually said, to the amazement of our patients and ourselves, we found ketamine produced rapid, and profound, and surprisingly durable antidepressant effects. This was a case where serendipity favored the prepared mind, I think. The history of that would move to that Dennis Charney then moved to the NIH and replicated this study. And this, I always say, is a lesson to all of us in the field. All of us were well aware of this finding that was published in 2000 in Berman, but being academicians, we all spent so much time trying to figure out what was the mechanism. It really took 6 years just to replicate it, is what Dennis and Carlos Zarate did at the NIMH, just replicated that study, almost identical replication of that original study with a slightly larger group of 18 people. And from there, I think most of you are well aware of the history in terms of the highly consistent findings of rapid onset of antidepressant effects lasting for periods of days to weeks, and in some cases months after treatment. Now I want to move a little bit to more of the basic understanding and where things have evolved. And this is a classic case of reverse translational medicine, or what we typically say, instead of bench to bedside, this is actually bedside to bench. So based on those findings, things move backwards. And in psychiatry, we're really good at that. We haven't quite mastered going from bench to bedside yet, but we're pretty good about going backwards. So this is just a cartoon version, very diagrammatic version of what the glutamatergic tripartite synapse looks like, where glutamate is released from the presynaptic neuron, has its effects largely postsynaptically, and is cleared through the glial cell. The idea originally was that potentially due to damage on glial cells or for other reasons of high stress, there was high levels of glutamate, especially high levels of glutamate reaching these extrasynaptic NMDA receptors causing toxicity. And the idea was that if you could block those NMDA receptors, you may be able to remove that toxicity and prevent some of the damage associated with stress and the pathophysiology of depression. However, we start to realize that this really doesn't explain things very well. This would probably take much longer than hours to have an effect. And it really is just looking at a small portion of what we know ketamine does. So other work had been done, and we know that the GABAergic interneurons in the cortex exert tonic inhibitory effects on the release of glutamate, especially in pyramidal cells and some other glutamatergic cells in the cortex and in hippocampus. And when you block those receptors, and there's some evidence to suggest that this is one of the primary mechanisms, that ketamine at these lower doses more selectively blocks the excitation of these inhibitory neurons, you release that inhibition. And by releasing that inhibition, you increase glutamate release and then activation of the postsynaptic receptors, including AMPA, that may be minimized in the pathophysiologic model. And there's really nice evidence to suggest that this is a critical effect in generating the mechanism of antidepressant response. And a lot of this work comes from using AMPA inhibitors or AMPA blockers, where if you give concomitantly ketamine with an AMPA blocker or any of these other NMDA receptor targeting drugs, and this is just showing MK801 or the Roche compound, that you get this antidepressant-like response in the rodent model. But if you block the AMPA receptor, you lose that effect. So this is some of the best and earliest evidence that was developed to suggest that the release of glutamate and this postsynaptic activation of non-NMDA glutamate receptors was critical to the mechanism. And some more evidence to suggest that this release of glutamate is in fact critical comes from dose response studies. I mentioned before Bita Moganum's lab doing microdialysis, but she also, with stress, but she also did work with ketamine, showing that subanesthetic doses of ketamine, and these are in rodents, 10, 20, and 30 milligrams of subanesthetic doses of ketamine can rapidly release glutamate into the extrasynaptic space, extracellular space that can be picked up by microdialysis. And it lasts for about an hour or so, and then it goes back down towards normal. But interestingly, if you go up, and it's only a twofold increase going from 30 mg per kg to less than twofold, 50 mg per kg, you no longer see that increase in glutamate release. In fact, you see in both cases, just the stress of giving an intraperitoneal injection causes this bolus of glutamate release briefly. But when you start to go up in higher doses of ketamine, you actually block that. So it's this interesting finding that this rapid release, bolus release of glutamate occurs in an inverted U-shaped curve. And then there's other work using some in vivo microdialysis studies showing that this is fairly regionally selective in terms of its activation, largely in the prefrontal cortex, hippocampus, some in the thalamus, but not diffuse threat. Well, not in every region of the brain. And you can see this by showing that with 35 mg per kg, which is that subanesthetic dose, increases the metabolic activity in these brain regions. But if you go up to that 100 mg per kg, you actually decrease it. So again, really good evidence that there's a U-shaped curve. And one of the reasons why I always warn people that, if the dose of ketamine isn't working, it's not always let's go higher. That may not be the case. And we did some more work looking at this, and we could, using C13 magnetic resonance spectroscopy, which is a way of looking at the glutamine cycling, an indirect way of measuring glutamate release. We can see a very nice dose response curve in the rodents all the way up to 30 mg per kg, which is all relatively low subanesthetic doses. But when we go up to that higher dose of 80, we lose that effect on cycling. So it's just more evidence to suggest that there really is a more narrow, if you want to call it a therapeutic window, at least in terms of the glutamate release. And we were able to show that in the rodent model, at least, there's that inverted U-shaped curve with the antidepressant-like effect 24 hours later. So again, the higher doses, we actually in rodents, and that's been replicated many times, higher doses of ketamine actually don't have the same antidepressant-like effect as the lower doses. Timing-wise, we were able to do some work to show that it's a pretty short-lived effect. So after giving the dose of ketamine, in this case, it's interperitoneal, but it's fairly similar kinetics to an IV. We see this increases in cycling that lasts. It happens very quickly within the first 15, 20 minutes. And by 30 minutes, it's actually decreasing. By an hour, we're not seeing anything. And in fact, 24 hours later, when we're seeing these behavioral changes, we're definitely not seeing any increase in glutamate cycling. If anything, there's maybe a trend for a decrease, but really nothing major. And that is very much in line with what we see with the microdialysis studies. So it really is just to get to the point that it seems like there's glutamate release, at least in the rodent models, plays a critical role in generating these antidepressant-like effects, even though it's 24 hours later when we're not seeing a big increase in glutamate release any longer. So it suggests that it's initiating some cascade of event downstream. I just put this slide in here to show that this is some work Chadi Abdullah did while he was at Yale, showing that we can actually show these changes in glutamate labeling with glutamine labeling, suggesting the cycling is increasing in humans too. So it's not just in rodents that we see this. And there's even some clinical data suggesting that there may be some evidence of an inverted U-shaped curve. This is the RAPID study done, the consortium study looking at various doses of ketamine, a single dose IV, either 0.1, 0.2, 0.5, or 1 mg per kg compared to midazolam as the control. And you can see the dose that had the highest benefit, although this wasn't powered to really tell specific differences between the doses, but we could see that 0.5 mg per kg dose really did well, and going up to 1 mg per kg really didn't add any benefit to that response. So then I talked a little bit about the downstream effects. So I just want to continue with that. So what is the evidence? You get this rapid bolus release, but what is the downstream effects? And this was all work that was going on, now about 10 years ago, 8 years ago. And a large part of this was done in Ron Duman's lab, who really deserves credit for a lot of advancing our understanding of the molecular mechanisms of ketamine. So yeah, the paper that came out in Science, which again showed that inverted U-shaped curve with antidepressant-like response, where nice antidepressant response 24 hours later after 10 mg per kg dose, but 80 mg per kg did not generate that response. But then on the right, you start to see how there's a dose response curve actually looking at some of the cellular changes. In this case, looking at the phosphorylation of enzymes involved in the mTORC-C1 pathway, which is really a pathway that has a lot to do with controlling local protein synthesis in the brain. So really early evidence suggesting that there was this initial event occurring that is then kicking off a cascade that leads to increases in local protein synthesis. And then some later work actually showing that this local protein synthesis leads to increases in both receptor insertion into membranes, but also into the formation of new dendritic spines. So it's work by Ron Duman and George Agajanian showing that with stress, you get a reduction in these dendritic spines, you can see here, but then you can reverse that within 1 day treatment of ketamine, and work showing that these spines are actually active. Other work by Ron's lab and others really have went on to try to outline the critical components of that cascade that's responsible for the increase in local protein synthesis, increase in spine density, and ultimately what we believe is to increases in neuroplasticity in general. And so if we look at this in this cartoon version, this idea is that you start to get this increase in glutamate release, this increased activation postsynaptically of AMPA receptors, which then drives the mTORC1 pathway, but probably other pathways that drive local protein synthesis and ultimately leads to increased spine density formation, which is acting to strengthen dendritic and connections within neurons. So leading to a period of enhanced neuroplasticity. So again, the model that had been promoted was that stress, being one of the pathoetiologic factors in depression, leads to this decrease in connectivity within synapses, and that ketamine acts to reverse this by increasing that glutamate release transiently. And I think it's an important point that it's transiently, not a prolonged release, that initiates this cascade of events that reforms these connections. And that was a model that was, presented first, and that was, I still think, where the evidence is most supportive. But there are others that clearly come into play, other components. So the work by Lisa Monteggia suggested that it could actually be some of these activity independent or spontaneous activating Nmda receptors that could play a critical role, and that they are typically having large effects on the EF2, which is an enzyme that modulates local protein synthesis by itself. And some of Lisa's work suggests that by really having effects, blocking those spontaneously active NMDA receptors, you're actually increasing local protein synthesis. And work that converges with Ron's, and I'll go, this is Lisa's idea that by blocking the EFT2 kinase, you then can increase local protein synthesis, or at least stop the block of local protein synthesis. And then with activation, you get the increase in protein synthesis and increased spine density. So these converge on this endpoint of increasing local protein synthesis. They both have a necessary role for the neurotrophic factors, specifically BDNF, in generating this response. So although they give different explanations why this may occur, they both converge on that point. One of the things that may have thrown a little bit of a wrench in this story was some evidence coming out suggesting that R-ketamine may have effective antidepressant-like properties in rodent models. And it started to question, R-ketamine has about 1/5 the activity or the affinity for the Nmda receptor compared to S-ketamine. S-ketamine and R-ketamine is just the racemic mixture. So it started to question, how critical is the Nmda receptor in actually generating that antidepressant-like response? And that was even further questioned, a paper that came out of Todd Gould's group, suggesting that, HNK, hydroxyneuroketamine, which is actually a metabolite of ketamine, may be generating antidepressant responses in rodent models. In fact, may be more effective than ketamine itself. And interestingly, what they were seeing is the RR version, which is actually generated from the R metabolite of ketamine, seemed to be the one generating that antidepressant-like response. So it really started to question how important the NMDA receptor was at all. What I warn people here, and at each step I'll go back and hopefully during the discussion we can look at the things to balance this. This was all done in rodents, and there are several studies now not showing HNK to have those same effects, and some clinical studies suggesting that the clinical response in patients is not really correlated with HNK levels. In fact, there's some inversely correlated, inverse correlations with HNK levels, and it calls us into question a little bit. Now, I think all of these, nothing is definitive, either the positive or negative evidence, but I think these are all extremely interesting and exciting avenues to pursue, but you have to look at the data in toto before you start making major decisions. paper by Todd Gould and Panazanos recently tried to merge all this data together, not with the idea that not one of these mechanisms may explain everything, but in fact, they all may contribute something. And this is where I stopped trying to make my cartoons where it's just getting way too complicated to do this in an animation. But this idea that you may have effects on the glutamate release. And in fact, there's work suggesting that RRHNK may directly excite glutamate release and lead to increased activation of AMPA receptors. It just may not involve the blockade of the Nmda receptor. And then also the work suggesting that the blockade of these spontaneous Nmda receptors, Lisa Montegia's work, could also act through EF2 kinase to generate these effects. So it's this idea that you may not just have one single mechanism, but they do seem to converge either on the release of glutamate or on the fact of increasing local protein synthesis and the role of the neurotrophic factor BDNF. So that is one of the main storylines that I think has garnered the greatest support from data. However, there still are some real questions about other things that may play a large role. The idea of the opiate system. So a very eloquent study by Nolan Williams and Alan Chatsberg came out suggesting that, well, the opiate system may play a critical role. And probably most of you have heard about this, but this was the study where they were able to use a mu opiate receptor antagonist, naltrexone, to block ketamine's antidepressant, or at least attenuate ketamine's antidepressant effect in a relatively small group of people. This is an N of 12. So you always have to be careful in interpreting studies, with small N's like this. But it was very interesting and suggested that the activation of the mu opiate receptor may be critical in the response. This was followed by several other studies in rodent models that complicated things some. So there was not some direct effects, but Malinow's group and others suggested that even though it may not be direct effects on the opiate receptor may be necessary to garner some of these antidepressant-like effects in ketamine. And I know I also provided a commentary on Nolan's paper, where suggesting that it wouldn't be unlikely to think that the opiate system, the endogenous opiate system, would in some way be involved in the antidepressant-like effects of ketamine. We know that the endogenous opiate system's involved in the non-specific effects of placebo effects. You can block placebo effects on pain and even some placebo effects on mood by giving mu opiate receptor antagonists. So I think it's very likely that the mu opioid system, or the opioid system in general, plays a critical role, but I don't think the evidence and the affinity really isn't there to suggest that ketamine is having its direct effect on the mu system, on the mu opiate receptor. The other, and some of the last things I did really want to cover was the non-specific effects. And when I mean non-specific, I mean effects that aren't so dependent on that proximal effect of ketamine on a receptor. But what are the larger effects that this has? And we know that ketamine has pretty profound effects on cognition and perception when it's initially given. And this has led several of the skeptics in the field to say, well, a lot of what you're seeing is really just functional unblinding. And in studies where you have functional unblinding, you get enhanced efficacy compared to placebo. But it's also led others to hypothesize that it has some unique properties, either spiritual or some unique psychological properties that foster improvement or foster recovery from depression. Or it may actually enhance some positive social interactions that can be used. And a lot of this approach is used in ketamine-assisted psychotherapies, and this idea that you may be these non-specific or non-pharmacologically specific effects of ketamine that may have these effects. And with that, you start to think about, well, how can you tease that apart? And one of the things is to look at the relationship between dissociation and the antidepressant response. So there's a lot of interest in what's the critical role of dissociation, or this psychological change in cognition and perception, in being a critical component of the antidepressant response. And the data here is not clear. I think most of the studies that have been published suggest, at least for that first dose, there is an association between having some change in something like the CAD scale, something representing a level of dissociation. But there's very little evidence to suggest that there's a continued correlation. So after that first dose, that association between the dissociation and the antidepressant response tends to really become minimized. And I know with S-Ketamine, that data really doesn't seem to hold, that with the longer term treatments, that relationship between dissociation and antidepressant response really doesn't seem to hold. And also from that study we did with the RAPID consortium, we could show that with the CADs, the 1 mg per kg had a much higher effect on CAD scores, a much greater, basically a doubling of the dissociation. But yet on the antidepressant-like response, there was no benefit. In fact, the 0.5 did just as well, if not a little bit better. So I think the real answer is it's complicated. And hopefully we'll get a chance to talk a little bit about that. But I would say it's definitely not linear. So this is not a case where dissociation appears to be necessary or seems to be related directly in a linear fashion to the antidepressant-like response. But just to wrap up, the other non-specific effects of ketamine, and this carries over to other treatments like the psychedelic or other psychedelic treatments, is these other non-specific effects of expectation and conditioning are likely to play a really big role in generating these antidepressant-like responses. And this is just a really interesting paper, again, that came out of Todd Gould's group, but work with Luana Koelka, who is really one of the masters of understanding placebo response. But this is a study, just very quickly, I'll summarize it, showing that after getting a ketamine dose and being conditioned to the place where you're receiving ketamine, and this is rodents, so this is not humans, this is rodent study, this is mice actually, that you can just bring the mouse back into the cage where they got ketamine, and then it can generate that antidepressant-like response. That effect was bigger in males and females, but again, these are small ends, so you have to take it a bit with a grain of salt. But it is some evidence that conditioning can play such a large role in this antidepressant-like response. So, so it's not even getting the ketamine a second time that had that second antidepressant-like effect. It was actually just bringing them to the place where they got ketamine the first time generated the effect. So some really interesting work, and something that could really guide us in our treatment, how to optimize this. So just to wrap up, I think I'm right on time. I hope I am. I think some of the big questions that remain is can we develop novel improved antidepressants? Based on these models, it would suggest that AMPA potentiators may have a real role. Could we target the mGlu system? mGluR2 targeting drugs may have a big effect. mGluR5 drugs. How seriously do we need to consider the potential drug-drug interactions? So if we believe these mechanisms, then we have to really think carefully about the use of any GABAergic acting drugs, such as the benzos, glutamate release inhibitors, lamotrigine and others could fit into there, or mu antagonist drugs like naltrexone. What about the mechanistic reasons? What are the mechanistic reasons that lead us to special concern? Again, if we're worried about opiate activation, does that have any increased risk for dependence? Are there other things that make us really concerned from that sense? Or what do we know about the mechanism of action that suggests potential ways of optimizing treatment? So I think here, if we really believe in this neuroplasticity and this increased connectivity, can we use integrative therapies? And it's something I know my group is extremely interested in. Can we take advantage of these windows of opportunity to use treatments like cognitive behavioral therapy, like other forms of non-pharmacologic treatment to increase the benefit or sustain the benefit? And then if we understand neurobiology, we may know the optimal times when to do that. And then lastly is the question, is there just something unique in the non-specific effects of ketamine? Why haven't other Nmda receptor targeting drugs really proving as effective? And are we looking at something more non-specific, like these effects on cognition and perception, or spiritual effects that are driving some of this? And is this maybe an overlap with what we're starting to see with some of the other psychedelic medications? So I think these are some of the real interesting questions that we're yet to fully understand. Again, this is just a very short list of my collaborators that we've worked on in these studies. And really, I don't know if many of you knew, but Ron Duman, an extremely close colleague of mine, died just a little bit more than a year ago. But his lab was really central in helping us understand this, and he's greatly missed in the field. So I'll just leave it at that, and I think we have questions later on. Thank you.
Brilliant. Thank you very much, Jerry. Yeah, you're absolutely right. So we'll be reconvening in about 10 minutes now, when Carla Canuso will give her talk, followed by Celia Morgan. Do please continue to enter your questions in the chat. There's been some great questions coming through. And Jerry, thanks for a fantastic sort of roundup of the neurobiology. And it'll be good fun to discuss that in more detail, as you said, a bit later this evening. So see everybody in about 10 minutes. Thank you very much.
All right, so welcome back everybody to the Ketamine 2021 virtual conference. Before presenting the next two speakers, Dr. Carla Canuso and Professor Celia Morgan, I'd like to remind you to write your question in the chat below. We will then review and answer those during our discussion after today's talk, starting at 5 p.m. GMT. If you have any technical issues, please send a message to Hawk AV Zoom support in the chat below. Now, it's my pleasure to introduce you to Dr. Carla Canuso. Dr. Canuso is Vice President and Compound Development Team Leader of Neuroscience at the Janssen Research and Development. And today, she will present the S-Ketamine nasal spray long-term safety data. Following her talk, Dr. Celia Morgan, Professor of Psychopharmacology and Head of Psychology at the University of Exeter, will summarize the evidence on the effect of ketamine in combination with psychotherapies for the treatment of addiction. Dr. Canuso, over to you.
Thanks so much, Sarah, for the kind introduction, and thank you to you and Professor McShane and the organizers for inviting me to speak. I think that I think of this conference as marking the beginning of the COVID quarantine, since this was the very first meeting last year that I had to cancel and miss, and we all did because of COVID. So it's really a pleasure to be back with everybody today, albeit virtually. So I'm going to be talking about some of the long-term safety data that we have amassed at Janssen on our compound intranasal S-Ketamine. And as Sarah indicated, I am a full-time employee of Janssen Research and Development, and I'm a shareholder of J&J stock. So when it comes to evaluating safety, we're very fortunate at Janssen that we have very large and long-term data sets in which we can do this. And I think Jerry mentioned we have two authorized indications for S-Ketamine nasal spray, one in treatment-resistant depression and a second, more newly approved in Europe, indication in patients with major depressive disorder who had active suicidal ideation and intent and were in a psychiatric crisis. I'm going to be presenting data from our TRD program, which in itself has studied over 2,000 patients and for a period of up to 4 years. So what we're looking at here is really the phase 3 development program for intranasal S-Ketamine in treatment-resistant depression. So we had 2 short-term studies, Transform 1 and 2, in adults, and then a third short-term study, Transform 3, in patients greater than 65. And these patients were all then eligible to roll into longer-term studies. So we had our relapse prevention study or maintenance of effects study called Sustain 1, which adult patients from the short-term trials could go into, as well as a long-term open label safety study that ran for up to a year, Sustain 2, that folks could enter directly at some sites or roll over from our elderly study. And then we have another study that's a continuation study that is ongoing, and that is Sustain 3. And that study was really designed to be a continuation of care study that would continue until the drug launched in the 27 countries in which it was running. And now we have launched in over 50 countries, but we also have continued that study in the US as part of a post-marketing commitment with the FDA for collecting long-term safety data. So what I'm going to present today is primarily going to come from this study at the last interim analysis cut, and then I'll supplement it with some additional data that we have from the Sustain 2 study. But just for your reference, the data from Sustain 2 have been published by my colleague Eva Wass, and is in the Journal of Clinical Psychiatry if you want to see the full data from that study. But the data I'll present today, actually this is the first time that we'll be presenting the data from this data cut. So in the Sustain 3 study, we ultimately had 1,148 patients enter into that study that had been participating in at least one of 6 previous trials. And I showed you the 5. Let me just mention that we had a small proportion of subjects from the US that actually are or have participated in our ongoing phase 3 program in China. So there's an additional 30 patients from the US that have rolled into that study. I'm getting a little feedback on my audio. I don't know if anybody else is, but maybe if folks can put themselves on mute, that would be helpful.
Yeah, I've just muted them, Carla. Carry on.
Okay, thank you. All righty. So so the data cutoff that we'll be using is actually May 2020. So it's actually the study has been running a year longer than the data that I'll present today, and those data, the newest data, have just been analyzed and are being written up into a study report. So in this Sustain 3 study, it's entirely open label, and patients could have entered into the induction phase, which is the 4-week, twice weekly dosing, or the optimization phase, which was generally weekly, every other week, and if patients were fully stable, they could move to once monthly dosing. And it was really up to the clinician as patients rolled in from their other studies into this study, whether they would go back into an induction phase or into the optimization and maintenance phase. And it was really based on how the patients were doing. And I think this will become a little bit more obvious here. So you can see that of the 1,148 patients that went into this study, 458 enrolled into an open label induction phase, where they then had the reinitiation of that 4-week, twice weekly dosing. And then another 690 patients rolled directly into the optimization or maintenance phase, where they were then being dosed either as frequently as once a week, and then able to extend out to a period of a minimum period of once monthly. So on the left, you can see that most of the patients that enrolled in the induction phase continued on to the optimization phase with less than 10% of those patients discontinuing. And you can see the reasons for discontinuation listed here. And then of the ongoing, and newly enrolled patients in the optimization phase, you can see that we've had more discontinuations, but you have to bear in mind that, for some of these patients, the study has been going on for, up to 4 years. And the largest cause of discontinuation is the so-called other reasons. And many of those reasons are that, simply that, patients' lifestyle got in the way of them continuing to participate in research or continuing to be able to follow up with the treatment as required. So some of these patients were discontinuing because they moved to new areas or that they were not able to manage the logistical conflicts of the dosing. But then you also see the other reasons for discontinuation listed, including some patients who didn't respond and some patients, who just did not want to continue. But at the time of this data cut, we had over 800 patients continuing. So, and let me actually just say before I take a look at the data, because I realized that I don't have a slide on it and it's likely to be a question. So the dosing is flexible. So patients could be on 56, 84, or for the elderly patients, the 28 milligram. So I know a question that's going to come up is what dose were people generally on and what dose frequency were people generally on? And I can say for that, during this optimization and maintenance phase, it was about 45 of patients receiving the 56 and 84 milligrams, and then a smaller number with patients receiving the 28 milligrams, and the same for the patients receiving the medication frequency of weekly or every other week, and then less than 15% of patients receive dosing for at a monthly schedule. So who were the patients, or who are the patients? They're still ongoing. So these, were mean age of about 50 years old, including, the patients range from in age from, 18 to 75. Patients were predominantly female, at 2/3 of patients were female. Patients were predominantly white. And this really reflects the regions of the world in which the study is conducted. And you can see that below that the majority of patients are coming from European countries, both East and West Europe, and about 30% from the United States. About 60% of patients had some form of employment. And then we list here that about a quarter of patients had a pre-existing diagnosis of hypertension and were being treated or are being treated with an antihypertensive medication. And we list this here because elevation of blood pressure is a well-known side effect, a transient side effect of ketamine and S-Ketamine. So in terms of exposure, you can see that the median month of exposure during this trial so far has been about 2.5 years. That's the median. But you can see that there are about 15% of the patients that are ongoing that have been exposed for 3.5 years or more. So, like I said, it is a large and a long data set from which we can, evaluate long-term safety, I think, pretty well. So, in terms of the most frequent treatment emergent adverse events, both over the induction phase and over the long-term optimization and maintenance phase, the types and frequencies of the events are really similar. So we see dissociation, dizziness, nausea, vertigo, dysgeusia, or the bitter metallic taste that's associated with S-Ketamine and ketamine, and headache are the most common in the induction phase, and those same events present as greater than 10% in the optimization phase as well. But you have to appreciate that the duration of the optimization phase is far longer than the induction phase. But essentially, we did not see any new findings during this during the optimization phase in terms of adverse event frequency. Now, we know that dissociation is a well-characterized side effect of ketamine and S-Ketamine. I don't need to describe to this audience what that is. We saw pretty much equal proportion of patients experiencing this event to some degree that rose to the level of being considered an adverse event in both the induction and the optimization phase. Very few patients required treatment with concomitant medication for dissociation. And you can see there, the 0.6. And Jerry, you had mentioned in your talk about what drug interactions you see with benzodiazepines, and that is the treatment that is typically recommended for severe dissociative reactions. And we did not need to utilize benzos frequently at all. The one thing we have learned in some of our other data sets is that what we do see when benzos are used concomitantly is that we do see higher sedation rates without much attenuation of the efficacy, but it does seem to result in greater sedation. None of the events of dissociation resulted in a serious adverse event requiring, any sort of hospitalization or what was be considered medically important. And the vast majority of essentially all of these events, are transient, time limited, and resolved on the day of dosing. And very few led to discontinuation. So in terms of sedation, we saw pretty consistent rates of sedation at 5.5 and 7% in the induction and optimization phase respectively. Again, these are limited to the day of dosing. There's not been any need for any sort of resuscitation or medical intervention or desaturation of oxygenation that has been associated with sedation in these patients, and none of these events led to withdrawal from study. We've also carefully monitored events related to suicidality, and there's a number of terms that are included in this list, most specifically suicidal ideation, attempt, completed suicide, but then there are other terms like self-injurious behavior or intentional overdose that are also included. And what we've seen overall is that 1.5% of patients reported some degree of suicidality in the induction phase, and 4.7% of patients had events in the optimization or maintenance phase. Only one patient has died by suicide in this program, and any suicide event is tragic. This is an event that occurred during the optimization phase in a 48-year-old male with a previous history of self-injurious behavior. And this was reported. This was reported at the time that the drug was registered in the United States. So there have not been any new events in the subsequent years during continuation of suicides. We have seen less than 1% of patients overall have events of suicidal ideation or suicide attempt that have resulted in hospitalization. And of course, we not only do we monitor these events in our clinical trials, but now that the drug is registered, we do monitor these events carefully through MedWatch and FAERS database and evaluate the proportionality of these events compared to what the expected rate would be in this patient population. And to date, these rates are still falling below what we would expect to see in patients with both treatment-resistant depression and a history of active suicidal ideation and intent. But something to monitor very carefully. In the events in the trial, none of them were considered to be related to S-Ketamine or were doubtfully related to S-Ketamine based on the patient's history or the timing of the event relative to dosing. Now, I said that 25% of patients who enrolled in this long-term study have had a diagnosis of hypertension. Overall, we did see, we've seen about 16% of events related to increased blood pressure that were considered, treatment emergent adverse events. On the left, you see a slide or a picture looking at the rate of events per month over the course of the study, and then you can see the number of subjects that were actually treated or dosed. And basically, it looks like the rate of these events have remained pretty stable over time from induction to optimization. What I don't know, and because we only have sort of the preliminary analysis, to what extent these events were occurring in patients who had a history of hypertension. And but still the rates, are generally, about a 5% per month, and then the cumulative rate there. Most of these events have resolved on the day of dosing, and there was one event of hypertensive emergency, and that did occur in a patient who had a history of hypertension that was poorly controlled. But I should say that both in this study and in clinical practice, we do have parameters for blood pressure pre-dose that should be employed, prior to dosing. So patients should have stable blood pressure before receiving a dose, and with levels of below 140 over 90. So interstitial cystitis is a side effect that has been noted in street abusers of ketamine, and we've monitored for bladder symptoms over the course of the S-Ketamine development program, initially using very specific measures of bladder symptoms in our early studies, and then in our follow-on studies using simple reports of adverse events related to urinary tract symptoms. And over the course of the SUSTAIN-3 study, we have not seen any cases of interstitial cystitis. Of course, we have had cases of urinary tract infections, which have generally been deemed to be of an infectious etiology based in urinalysis. Since we did see a rate of 12.1% of patients with UTIs, we went back to a claims database just to get some context to look at the rate of UTIs in patients with TRD, and found that those occurred in about 14% of patients. So we feel that the data in our patient population are really consistent with what you would expect to see in the TRD population. And so we have not seen, any interstitial cystitis or ulcerative cystitis thus far. Now, overall, we saw 13.1% of patients having serious adverse events. And just to remind people, serious adverse events are distinguished from treatment emergent adverse events in that they require hospitalization or are considered medically important or life-threatening or deemed to be, that medically important by an investigator. But only 1% of the patients with SAEs of all the patients who had SAEs, the only event that occurred in greater than 1% was depression, leading to hospitalization. And this is, likely related to the underlying condition. And the rest of the events were various. The majority of the events were not considered to be related to treatment. We have had 4 deaths over the course of this SUSTAIN 3 study, and I did speak about the 48-year-old male who did die by suicide during the induction phase, and that occurred early in the course of this study, as did the next 2 events of a individual, a male who died in a bicycle accident. He was struck by an automobile during the optimization and maintenance phase, and a 73-year-old female who died by myocardial infarction during the optimization and maintenance phase. And both of those events were, I think, 6 days after the last dose. And at her last dose, her blood pressure was normal. So those events were considered unrelated to study medication. And then unfortunately, we've had a patient who died from COVID pneumonia during the optimization phase, and this was a 66-year-old male. So there were 4 deaths in this data cut that ended in May of 2020. Unfortunately, we have had another COVID death in the interim that will be included in the next analysis of the ongoing study. So one, important question is, what are the long-term effects of S-Ketamine on cognition? And we do know that the short-term effects, there is altered cognition, but what are the long-term effects? And so in this extension study, we have assessed patients with a Cogstate battery, as well as the Hopkins verbal learning test, the revised version. And so we have data on 130 patients out to 148 weeks. But beyond that, we have very small data sets. But if you look at the overall group mean performance on cognitive tests from baseline to 148 weeks, we do not see any change in baseline or slight improvement in cognitive performance. And this was observed both in the induction and optimization phase. Now, we have seen an interesting finding in patients greater than 65 in both this study and in our previous SUSTAIN 2 study. And I'll show you some data in a moment because it's actually been plotted for the earlier study. And on the overall cognition, including higher cognitive functions, we do not see any change from baseline to endpoint. But we have seen some slowing of reaction time in patients greater than 65 on simple and choice reaction time. And this, simple and choice reaction measure elements of attention and concentration. But the clinical meaningfulness of this slowing is difficult to ascertain because we don't see any changes or worsening on the higher cognitive functioning of working memory and visual learning, executive function, verbal learning. So it's really not clear what that slowing of reaction time is related to, although some who study normal cognitive aging have suggested that there is intrasubject variability as a part of normal aging, which may be what is leading to this slight slowing of reaction time in elderly. And you can also see that, by week 148, we also have very few patients from the elderly data set. So it was an N of 16 here. But here's the plot of the verbal learning from our double-blind maintenance phase. That's SUSTAIN 1, where you see that the patients who continue on S-Ketamine actually have an improvement in verbal learning, and on the top of the slide, and that in an open label safety study, SUSTAIN 2, that also improved. And then here you can see that slight slowing of the reaction time in the elderly patients that was reported in SUSTAIN 2, and a similar effect that I just noted in SUSTAIN 3. So I just want to note quickly, because I see I'm over time here. We also have evaluated withdrawal symptoms, another important area of study for assessing long-term effects of intermittent dosing of ketamine and S-Ketamine. And thus far, we have not had any reports of any sort of withdrawal symptoms across our long-term safety studies. We did not specifically assess withdrawal in SUSTAIN 3 with a formal measure, but we did use the physician's withdrawal checklist in SUSTAIN 2. And what you're looking at here is a graph that looks at the individual symptoms of the scale at the end of the study, and then weeks 1, 2, 3, 4 following exit from the study. And you really don't see any difference over that 4 weeks of follow-up on any of the symptoms that are related to withdrawal. And of course, many of these symptoms are similar to symptoms of depression, but are not unique to withdrawal, but we just did not see a signal there. So to summarize and wrap up, we really have no new safety signals that have come out of our long-term safety data now with intermittent dosing of up to 48 months, and everything has been consistent with what we saw both in our short and longer-term studies. And that the findings that we know to be directly related to S-Ketamine, such as dissociation and sedation, are transient and of mild and moderate intensity, and that essentially we did not see any new signals on the effect on cognition or withdrawal symptoms. So I will stop there. And I understand that we may be having some issues with the chat, but maybe they'll be fixed by the time we go to our discussion. So thanks.
Yes, that's correct. And apologies to everybody since we had a problem with the chat, but you can send your question. I think it seems like you can send your question directly to us. So if you want to send those to me or to Rupert or to Oak AV Zoom support, then we will merge them together and get ready for our discussion. However, thank you so much, Dr. Canuso, for such a comprehensive review of the S-Ketamine safety data. And now I guess it's time to introduce our next speaker. So we are delighted to have Professor Celia Morgan here with us today. She will present the most recent behavioral studies and clinical trial on the effect of ketamine in combination with psychological therapies for alcohol disorder. Professor Morgan, over to you now.
So I'll mute myself. Thanks, Sarah, and thanks everyone else for the interesting talk so far. So I'm going to talk about ketamine and the treatment of addiction. Just some disclosures before I start. Just move that. And I'm only going to talk about the psychological effects of ketamine today, not denying the neurobiology. And obviously, Jerry did an amazing job of covering it. And I hope perhaps we can get into a discussion in the breakout rooms of how some of these things relate to neurobiology. But I'm just talking about the use of ketamine in addiction treatment. And I guess this research has really had quite a different course to the depression work for a variety of reasons, I think. So I think maybe, there's very little research in this area for a starter, but perhaps getting funding for these studies has been even harder than in the work with depression, because people perceive this inherent risk of giving ketamine to addicts. And I understand this very well, as I've spent a good proportion of my career researching people who have ketamine problems and working with them. So I understand that can be damaging, but so I think also there's another a kind of a difference between the depression and addiction research, in that most researchers in this field, and there aren't very many of us to be fair, but have taken quite a different approach, historically intended to embed ketamine infusions in a psychological therapy context. And this approach seems to be gaining ground. I'm really excited to hear Jerry mention this and see Sam Wilkinson's talk about CBT tomorrow. So I think it's brilliant that more people are considering adjuvant psychological therapy, because to my mind, we're kind of missing a trick if we don't do this. I think perhaps why in addiction, we've tended to embed ketamine within therapy may be to do with inherent risk, but also to do with the lineage of the research. So actually, ketamine research in addiction clinically has been going on longer than the depression research, thanks to this guy is Evgeny Krupitsky, who's a psychiatrist in Russia, and he was researching ketamine in the 80s and 90s in Russia and had to stop his program of research when the drug became Schedule 1 over there. But yeah, he's done an enormous amount of research looking at ketamine very much in the context of a psychological, kind of transpersonal psychodynamic therapy. But Evgeny found some amazing results, actually. He gave high dose ketamine. So in this case, he gave 3 infusions of, it was between 2 and 3 milligrams per kilogram of intramuscular ketamine to a large number of inpatient alcoholics. So they were in treatment for alcohol use disorder. And what he found was these really remarkable reductions in relapse of about 40% at 12 months. So around only a quarter of the placebo group remained abstinent at 12 months, but actually 2/3 of the ketamine group, which is incredible. And he found similar findings in opioid addicts. So these studies weren't RCTs, but they're really important basis for the future work. And then after that, there was just a huge hiatus in research looking at ketamine and addiction. And I think as Jerry elegantly described, the emergence of the use of ketamine as an antidepressant really helped to kickstart this again and opened up a route to exploring these things in addiction. So there were some experimental lab studies. I did some way back looking at potential reductions in drinking following ketamine. And then Elias Dakwa at Columbia, who's really the other person who's done research in this area, began looking at cocaine, and he did some really interesting laboratory studies with cocaine users showing a reduction in desire for cocaine following ketamine. And then this is Elias's study, probably the first clinical study in, it was in cocaine use disorder. And he used the active placebo midazolam to compare to ketamine, which is a really good idea. And he, so they looked at cocaine use disorder. They were predominantly free-base cocaine users. There were slight differences between the groups in that in the midazolam group, there were more free-base cocaine users. But in this study, he gave patients came to stay in the facility for 5 days. And on day 2, they had an infusion of ketamine or midazolam. And then this was embedded in mindfulness training. And then when they were discharged, they did mindfulness-based relapse prevention, which is a treatment used in addiction for 5 weeks. And you can see what I think is actually really remarkable about this is parts of retention. So in the ketamine group, there was only a quarter of patients dropped out. In the midazolam group, it was 60% of patients. But also these reductions in cocaine use over the treatment time after they've been discharged from the inpatient unit whilst engaging with the mindfulness-based relapse prevention. And there was a reduction in cocaine use in the ketamine group compared to the midazolam. So that is really interesting. And Elias has also conducted a study in alcohol use disorder. So this is a pilot approach, giving a single infusion of ketamine after all patients have been given motivational enhancement therapy. So this is a kind of counseling approach that helps individuals resolve their ambivalence about engaging in treatment and stopping their drug use or alcohol use, and aims to evoke rapid and internally motivated change. So this was a brief succession approach delivered over 5 weeks. And then patients had a single infusion of ketamine or midazolam. And again, the retention here with ketamine was much greater. So in the ketamine group, there were no dropouts, but a quarter of the midazolam group dropped out. And this was just a note to myself, really, about the measure. So you can see here actually on the graph that in the ketamine group, there were much lower numbers of heavy drinking days compared to the midazolam group. And I think that's a really interesting, important effect. Now I was just looking, because the guidance on how to assess heavy drinking days from NIAAA is 4 drinks per day for men and 3 drinks for women. And we've just kind of accepted this in alcohol research, but I started to look, and I don't think there's any evidence that women or men are less likely to relapse after 3 drinks. So maybe proposing changing that. And actually there's some gender differences in this study that make that difficult, but I still think it's an important and really well conducted study with an active placebo. So in these series of studies, there's no investigation of ketamine alone in the treatment of addiction, but also it's quite difficult to tease apart what's the effect of the therapy interactively, because the therapy was given to everyone in Elias's study and only to one group in Evgeny's early work. So that's something we set out to do with our research. So this is also our research questions were, does ketamine reduce drinking and alcohol use disorder? And then we wanted to look to see if psychological therapy could enhance ketamine's treatment effects in addiction. So this was the design of our study. So we designed it, as I said, to assess the synergistic effect of ketamine with therapy. So we wanted to include a placebo, not just for the drug, but also for the therapy. So we called the study the CARE study, and this stands for ketamine in the reduction of alcoholic relapse, which also I think gave the study a little less off-putting feel to people talking about ketamine, because they had a sense of kind of care from the outset. This study, we were lucky to get funded by the Medical Research Council in the UK, and we included 96 patients with moderate to severe alcohol use disorder. And they were randomized to receive either 3 infusions of ketamine at 0.8 milligrams per kilogram or 3 infusions of placebo. And then amongst those 2 groups, half of the ketamine group received our CARE therapy, which was a specially designed program, essentially based on mindfulness-based relapse prevention, but also including aspects about what we know about ketamine effects and to support people around the ketamine infusion. All people received alcohol education, and this was designed for the study, so we could include a placebo therapy, as I said. So it would control for time spent with a therapist, but with no active psychological component, because we know there can be non-specific effects of just spending time with an individual. So, and then similarly in the placebo group, half of those received the therapy and half of those received education. And this is an overview of the treatment. So patients were screened and they were fitted with an alcohol monitoring bracelet. So we used the SCRAM bracelet to measure alcohol through sweat, because about 1% of your alcohol is excreted. So they wore that for the duration of the treatment. And then, so upon randomization, so screening happened, people were required to be abstinent upon entry to the study. So if they needed to reduce down, they were given time to do so, or supported through a detox. On entry to the study, on their first session, they received an hour and a half of psychological therapy and then an infusion of ketamine, and they came back 24 hours later and received another session of psychological therapy. And they did this for 3 weeks. And then on the 4th week, they had their final session, and all these sessions were an hour and a half. So they were learning psychological techniques with a relaxation or mindfulness exercise in the middle. And the relaxation we also did with the alcohol education group. So they had these 7 sessions in total of psychological therapy and 3 infusions. And then they came back at week 12, week 24, so 3 and 6 months for follow-up visits. So we had a lot of exclusion criteria. Some of those, which I just wanted to highlight, were taking antidepressants, because this meant quite a lot of people weren't eligible for the study, and I think is relevant to our findings. Current diagnosis of substance use disorder, and very poor liver function, which was quite limiting when working with alcoholics. And we excluded people with regular ketamine use, but if they'd occasionally used it up to 10 times in the past, that was permitted. So in terms of feasibility in our study, it would differ quite a lot from Elias Dakwar's work in that we had quite good retention. So actually only 1 person dropped out of each of the ketamine groups due to not being able to tolerate the drug. But for various other reasons, we ended up losing 7 people from the ketamine group. I mean, some of them were not being able to fit in with a quite intense treatment plan. We had change in eligibility when someone developed suicidal ideation, which was mild, but and then a few people were lost to follow up, so around 1 person in each group. So we had really good retention, and then But yeah, across the groups, it was broadly similar, but slightly higher loss from the ketamine group, so 7 and 5, and then 4 and 3. So obviously there's an intention to treat analysis. So that slightly impacts the outcomes. In terms of the patients we recruited, I won't spend too long on this because I'm conscious of the time, but overall, they were predominantly male, but quite a good gender split in their 40s. They had an average of 7 items endorsed, or 7 or 8 on the DSM-5, which meant they had severe alcohol use disorder and heavy alcohol users, but most were abstinent. And this is when they alcohol use at randomization. So some of them stopped drinking that day, but yeah, they've managed to reduce down considerably. In terms of safety, this is a very small consideration of safety compared to Carla's amazing, huge studies, but we had a variety of AEs, but most of them were mild. The only severe one was suicidal ideation. The ones that you would expect, nausea and confusion, but no serious adverse events related to the drug. In terms of drinking outcomes, so our results panned out as we hypothesized. So the confidence intervals are wide, as you'd expect with a phase 2 study. But so if we take it from here, where this is the percentage of days abstinent, so on entry into the study, the majority of participants were abstinent, and then there's decreased to nearly 100% at the end of treatment. And then what we saw is a kind of divergence in effects here, where the placebo group drop off quite quickly there. Days abstinent reduces to 6 months to the lowest. So these are the placebo and education. The next lowest were the placebo and therapy, and then ketamine and education, and the ketamine and therapy did the best. And these differences are of significant in terms of the confidence intervals. So, and this is reflected in our some of our objective indices, which I don't have time to fully present, but we looked at liver function, and you can see here, so here higher scores are poorer liver function, and red are the placebo group. So they start out with poor liver function, which improves across the study. This is up to their end of treatment visit. And then the placebo group's liver function starts to worsen again as their drinking increases, but the ketamine group remain low. And just on some of our secondary outcomes, we have very low levels of depression in the study because we excluded people on antidepressants, and even though some people came off their antidepressants, and the reasons for that I can go into, which were more to do with the funder. But yeah, for that reason we had low levels of depression, but we still saw a significant reduction in depression in our ketamine group compared to placebo at 3 months. This then tapered off by 6 months, and a similar kind of pattern with anhedonia, although they're slightly lower in the ketamine group to start with, but decreased over the course of the study, and then looks like it's starting to increase again, with a significant difference between the groups at 3 months. So a kind of interim summary, although I might just go slightly over time, I think, is that so ketamine on its own reduced alcohol use and severe alcohol use disorder, and this was maintained to 6 months, which is, I think, really impressive given we only gave 3 infusions embedded in psychological therapy. It suggested that this would enhance the treatment effects, so that our treatment effects on drinking were enhanced by embedding the ketamine within a psychological therapeutic context, and this was reflected in improvements of liver function. And we also saw reductions in depression and anhedonia at 3 months. These tapered off by 6 months. So I wanted to talk very briefly about some qualitative analyses we conducted. So I think these are really important when we're trying to understand the mechanism by which ketamine works. We're actually talking to the patients involved, and they allow us to dive a bit deeper into how ketamine might work. And I don't have time to really do justice to this. These are the main themes that emerge from the qualitative analysis led by Marva, who's a PhD student, and Joe in our lab. And they were setting the contradictory nature of the ketamine experiences and transformative effects. I'll probably just go on to the contradictory experiences as we are quite short of time. But so a common theme that came out was contradictory nature of the acute experiences of ketamine, that there were things like a lot of fear, but also relaxation. And one of the contradictory experiences were identified was the sense of disembodiment, and these are some of the patient reports. The feeling of my body disappeared. It was like I was amoeba. As far as I was concerned, I was dead. It's like the universe was surrounding me and I was a tiny particle. But this kind of contrasts with a lot of the reports we also got from patients, that they felt this sense of connection during the infusion. We were all connected. There is the connection between all things to bring us out of the prison of addiction. And the sense of what was important was my relationship with the universe and the universe as a whole, the relationships with people, entities, nature, wildlife. So on the surface, this seems contradictory, but actually thinking about it, you could think this kind of disembodiment and disconnection would have as a natural consequence connection. So this disconnection from yourself means that inherently you'll connect with large areas of life that we're part of. So things like your relationships, nature, humanity. And this has been termed the small self in all research. And this sounded to us like quite an important therapeutic process. And it's something that Jerry mentioned briefly in his talk, that the literature around the relationship between dissociation and treatment outcomes has been quite equivocal. And actually, Miriam, who's a postdoc in our lab, did a systematic review looking at the links between dissociation and treatment outcome across all studies, and found in about 25% of studies, there seemed to be a link between scores on the CADS, which is the Clinician Administered Dissociative State Scale. But actually, that the majority overall, there didn't seem to be a net effect, which is quite interesting. We wonder whether maybe the CADS is not the best scale to assess this. And actually looking, this is a study from Elias, sorry, I haven't got the reference on there. I must have got chopped off. This is a follow-up study from Elias Duckworth's study in alcohol use, where they looked at the relationship between, this is the Hood mysticism scale. So it assesses mystical effects of drugs. And then they looked also at the CADS. And you can see there's a greater association here. So the scores on the Hood mysticism scale predicted heavy drinking days after the infusion. And the CADS score was only of marginal significance. I actually looked across our study, and we used the scale that I developed to assess acute ketamine effects quite a while ago in my PhD, I think. And it ranges from things like dizziness, nausea, impaired concentration, unsteadiness. And I aggregated the effects across the 3 infusions, and what we found was the most predictive, and it's quite strong, like a large effect size here, were out-of-body experiences, were the most predictive of the percentage of days abstinent at 6 months. So I thought that was really interesting. These are preliminary analyses, and I must caveat they weren't in our statistical analysis plan, so they're only exploratory. But I thought that was quite interesting. I don't know really, Sarah, would you like me to stop here so everyone can have a break? I could do about 5 more minutes, or what do you think?
Yeah, I would continue if it's okay.
Okay, cool. That's okay, that's great.
Sure.
I don't want everyone to miss out on their break. But yeah, so this I thought was quite interesting. This combined with what we'd heard from our patients in our qualitative analysis of these feelings of connection stemming from disconnection. And I started thinking about dissociation and disembodiment. So with out-of-body experiences, I think disembodiment might be a better term, or depersonalization, but that has some wider connotations. So we know that these kind of disembodied feelings or depersonalization occur in response to trauma. And this can be really damaging and really difficult when they occur unexpectedly and over prolonged periods of time. And we know they're a core feature in a number of psychopathologies. And I know we're going to hear about PTSD next, I think so. And we know, and understandably, that depersonalization has been viewed largely through a pathological lens. But it's still clear that nobody really has a handle on exactly why we dissociate when trauma happens. And one suggestion has been this is a kind of functional response of the brain to protect us from overwhelming anxiety. So this might be able to enhance things like our chance of survival in a life-threatening situation by heightening our alertness and dampening down what could be very disorganizing levels of anxiety and stress. But actually, interestingly, another literature has found dissociative experiences occur in response to awe. So by awe, we mean the feeling of being diminished in the presence of something greater than the self. So this is normally inspired by things like nature and art or perceptual vastness. So this idea that dissociation and this kind of disembodied feelings happen in response to awe suggests that maybe the theory of the etiology of dissociative experiences in trauma might be incomplete. So what I wanted to tentatively suggest is that maybe these states are more than just an epiphenomenon of a protective process in the brain, but actually perhaps the psychological manifestation of a process of a way of encoding information in our brain that doesn't fit within our normal frames of reference. This also fits with the spike in plasticity and neurobiology and the neurobiological studies that we see that happens following these events. So I think I'd be really interested to get into that in the breakout rooms later. So anyway, to kind of conclude, I've tried to draw this out. And so here I've kind of conceptualized awe and trauma, and awe by no means has to be a positive event, but sometimes is, as these kind of challenging experiences. And thanks to Irini, who's a researcher in our group, who's really helped with this. Yeah, so these are conceptualized as challenging experiences, and using disembodiment as a kind of broad term for disconnection between any of the normal thoughts, emotions, and bodily feelings. And so this can be seen as a kind of psychological manifestation of an adaptive brain state. So here I've called it an observer perspective, but this basically might mean that we're able to process and rapidly learn from extreme experiences. And maybe that's the function of these feelings and these psychological manifestations of these observer states. Obviously in all it's not in all contexts that this is a positive event. So with some of our ketamine infusions, we see growth, and this disembodiment is related to connection and integration, and that's probably very much the context around the event, because certainly in other circumstances, this may lead to things like alienation, fragmentation, and then getting kind of hooked back into a trauma loop, as it were. But yeah, I thought it's quite an interesting way of thinking about some of the effects of ketamine and how some of these processes of disembodiment and disconnection might relate to some of the treatment effects that we're seeing. So I'll skip over transformation, although it's obviously very important as part of the ketamine experience. This was the other main theme that came out of our qualitative analyses. But just to conclude then, so overall, there's an emerging body of evidence that ketamine improves outcomes in addiction. And it seems like it's better when embedded in therapeutic context, although our study is really the only one to have tested that so far. So related to what Jerry was saying, I would say that maybe the psychotomimetic and dissociative effects aren't in fact nuisance effects, that they're actually an important part of the therapeutic process. And they unlock psychological flexibility and enhance our motivation for change. And so I'd suggest that it would be important that we try and explore how best to harness these unique effects for therapeutic gain. So just wanted to say massive thanks to some of the key people involved in the study and Awaken Life Sciences who are taking it forward to phase 3. So yeah, I'll stop sharing now.
So, well, thank you so very much, Celia, for presenting this fascinating and novel data on the effect of ketamine and the combination of ketamine and psychological intervention. So I really encourage everybody to keep writing your question in the chat, because I think we're going to have a very interesting discussion later on, but I think it's now time to take a short break, and we'll see you again at 4 p.m. UK time sharp. Thank you.
Okay, so it's a great pleasure to welcome you back. And we've got 2 talks in this next session. We're going to start with Adriana Feder, who, and then we're going to go on to Paul Glue. He's coming from New Zealand. I don't know if he's awake yet, but we're dragging him out of his bed for a very early morning talk. So we'll hope that he'll join us and that his alarm clock's working. But first we've got Adriana's going to talk to us. She's Director of the Trauma and Resilience Programme and Co-Director at the Ehrenkrantz Laboratory for the Study of Depression and Anxiety. And she's Associate Director for Research on the Mental Health Programme and Associate Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai. She kindly did a presentation for us at the International Journal Club the other day, and it was so good that we got her back. So thank you very much, Adriana.
Hi, can you see my screen?
We can see your screen and it looks very nice.
Perfect. Okay, so Hello, everyone, and thank you, Rupert and Sarah, for the opportunity to present at this exciting conference. First, my disclosure related to patents for the use of ketamine and the treatment of PTSD. None have yet been licensed. So, following the findings on the effectiveness and efficacy of ketamine for TRD, treatment-resistant depression, we embarked at Mount Sinai on studying whether ketamine might help patients with chronic PTSD. And this is because there is a lack, insufficient therapies, both medication treatments that are sufficiently efficacious for PTSD, and also trauma-focused psychotherapies. Although they have the most empirical support, they have pretty high rates of non-response or partial response or treatment dropout. So following we started over a decade ago with the first RCT of single ketamine infusion crossover with midazolam at Mount Sinai, and we had some encouraging positive results. And so we then embarked on this randomized controlled trial of repeated dose intravenous ketamine for PTSD. And as Rupert mentioned, I presented the findings recently at the Ketamine Journal Club. And so I'm going to go over these findings briefly to summarize them, and they are published now. They were published in February. So this was a study where patients with chronic PTSD were randomized either to receive 6 infusions of ketamine, the usual dose of 0.5, 3 times a week over 2 consecutive weeks. So typically, not always, Monday, Wednesday, Friday, Monday, Wednesday, Friday. And the primary outcome was at the 2-week time point, usually the following Monday. And it was a double-blind, randomized clinical trial, and the other half were randomized to midazolam as psychoactive placebo control. Briefly, these were the inclusion criteria: men, women. They had to meet DSM-5 criteria for PTSD, and significant severity of PTSD symptoms. They had to have a CAPS-5 score of at least a 30, which is several points into the moderate range, moderate to severe. And then a couple of exclusions. So we excluded individuals with serious unstable medical illnesses, but if they had, for example, well-controlled high blood pressure, hypertension, diabetes, those were not exclusionary. We also excluded individuals who had comorbid bipolar disorder or chronic psychotic disorders such as schizophrenia. Past history of drug or alcohol use disorder was fine as long as they didn't meet criteria for the previous 3 months, and they didn't have a history of recreational use of ketamine or PCP. And a range of concomitant psychotropic medications were allowed. We did not allow concomitant opioid medication, and also participants on long-acting benzodiazepines, like clonazepam, for example, were excluded. But if participants were taking short-acting, even in the daytime, prazolam, lorazepam, benzodiazepines, we would hold the dose. We would ask them to not take their morning dose during the one just prior to the infusion. So this is a consort diagram. And so as you see, 15 were randomized to ketamine and 15 to midazolam. So this is was a pretty small study, and originally planned to go to 40, but we did interim analysis that were partially unblinded conducted by an independent statistician, drug A, drug B. And because there was a significant separation, we, in consultation with the DSMB for the study, we decided to end the study with 30. So briefly, as you can see, the mean age was about 39 years, and it was about the 3/4 female, the sample, and a range of ethnicities, and they all had on average, very chronic PTSD of about 15 years. And the CAPS at screening, CAPS-5 score over the past month was around 40 to 41. So that's pretty severe. So some, there was a range, and MADRS score for depression. You can see there comorbid, the rates of current diagnosis of comorbid MDD on the SCID was about 2/3 or 3/4, 2/3 to 3/4, and a range of traumas. Primarily, the most common one was sexual assault or molestation, followed at the bottom where it says primary trauma. You can see the range of traumas. This is a summary of the findings from the study. So you can see on the left that there's a clear separation from 0 to 2 weeks, the primary outcome. So the improvement on ketamine, the red line, was robust and rapid. In fact, we found that we did a 24-hour, so those who would go on to improve significantly on ketamine were already better at 24 hours. And compared to the flatter tracing for midazolam. And really the improvement did not differ across the 4 symptom clusters of PTSD per DSM-5, with the exception of, so they were all significantly different except at a trend level. The difference was a trend level in the arousal reactivity subscale or symptom cluster. And we thought maybe this is due to midazolam helping some with perhaps sleep or other arousal and reactivity symptoms. It's a hard comparator, as you know, to go against because it is an anxiolytic. So it could have temporarily improved some of these symptoms. And if we define the response as based on several other studies having defined use this criterion for response, and basically in the ketamine group, 2/3 or 67% were considered treatment responders compared to only 20 in the midazolam group. And these are some selected quotes, which are also included in our published paper in the online supplement. And you can see these are ketamine individuals who responded very well to ketamine. I don't feel my life is going to end anymore. Before it made it impossible to plan a future. Another patient said, I feel like a normal person. And it doesn't, the thought, she's no longer thinking about suicide all the time. And she has to dig out the memory of her trauma as if from an addict. Before, she used to have a terrible feeling when these memories would pop up. And then another participant said, I feel like I have energy and want to do things again. And I feel like I have made peace with the trauma. I could go past it, and a feeling of gradual acceptance. So we obtain these quotes over time. Sometimes, we were asking, and some of these are from the second week after the first week of infusion. Some of them are after the primary outcome, but sometimes we would even see that some of these beginning to emerge even the first day, a couple of hours after the infusion. And there was also improvement in comorbid depressive symptoms, also rapid, as assessed with the MADRS. And this is what we see. So the 0 time point here is the 2-week primary outcome. So the median, so the majority, these are the 3 who had a response or placebo or psychoactive placebo response to midazolam. And of the 10 of the 15 individuals who got ketamine who were considered responders, most of them relapsed. The median time to relapse was a whole month or 4 weeks after the primary outcome. So 6 weeks after the first infusion, when most of them were already feeling somewhat better. And so what this shows is it seems that ketamine for PTSD repeated a course of 6 infusions seems to prolong maintain the improvement over a few weeks. So I wanted to focus a bit more today on our MRI findings, and wanted to mention Dr. Agnes Norbury, who's a postdoctoral fellow working with me and my research team, and she led and conducted these analyses. So you can see here that 2/3 or 20 participants of the 30 were able to complete 2 scans, one before any infusion started, and then the post-infusion scans happened usually after the 4th infusion, but sometimes after the 6th infusion, depending on scheduling. And it didn't happen the day of infusion. It was at least 24 hours after the infusion. And you can see also in this subset, we see a robust difference. In the pink is the pre-infusions, and the post-infusion scan is the blue. So you see a robust improvement in ketamine, but not so in midazolam. And what there were 2 tasks that were administered in both scans, and resting state connectivity. One is the Hariri et al. Very well-known task that elicits robust amygdala activation. And then this one is a task developed by Lisa Shin, and it's face stroop. And basically, there's a congruent condition where the word and the face have the same, they're both fearful face and the word fear. And this one is the incongruent condition where it says happy, but the face is fearful. And they're supposed to press the button that indicates fearful without being distracted by the word happy. And then here's participant is asked to look at the fixation cross during their eyes open and not do much of anything. There's no task. And there were a bunch of other measures that Dr. Norbury included in the model, clinical covariates, socio-demographic predictors. There were about 50% of those who were scanned were taking at least one concomitant psychotropic medication at stable doses. So I wanted to mention that this was allowed, and some patients were taking several medications, some of them just one psychotropic medication. And then we also included in the model other, the CADS, dissociative symptom, psychotomimetic, manic, one question from the Weimars, and then any physical somatic side effects that patients experienced. The analytic approach that was used was based on pre-hypothesized regions of interest that have shown, that have been found to be abnormal and abnormal connectivity in studies of patients with PTSD. And they're summarized here: dorsal ACC, rostral, ventromedial PFC, anterior hippocampus, anterior insula, and amygdala, and the relationships with them, between them, connectivity. And because there were so many variables that were included, this regularized regression approach was used, elastic net, which actually deals well with multicollinearity. It's used when there's a small sample size and the number of measures, predictor or correlate measures here. And I want to say what we are predicting is improvement in PTSD symptoms as measured with the CAPS from pre to post, from pre to the primary outcome. So correlates and predictors of improvement in PTSD symptoms. So when there's more measures than the number of subjects, and then this method was used where you rotate and leave one subject out for cross-validation. So you train the model in the others, so there are 20 subjects, so in the 19 subjects, and leave the other one out and try to see if you can predict the findings in the one that was left out. And then you leave another one out and put that one back in. So it's as if you had 2 data sets, a training one and a confirmation one or validation. And because of the small sample size, we also pre-registered the data, all this plan online before doing any analyses. And so briefly, these were a summary on correlates of symptom improvement. And basically, there were 11 predictors or correlates. So the dependent variable is improvement from pre to post ketamine infusions, all 6. In the CAPS-5 or specifically PTSD symptom improvement. And you can see in green, there are 11 of the Hariri, 11 emotional faces tasking MRI. This one is connectivity between the ventral medial PFC and the amygdala. And then there's 8 from the Lisa Shin task were entered from the face stroop, and then 9 from the resting state connectivity variables. And then here you see the demographic characteristics. And so here is, regardless of drug agnostic, an increase, the most robust predictor of symptom improvement from pre to post treatment after the 6 infusions was an increase in functional connectivity between the ventral medial PFC and the amygdala during emotional face viewing. And then looking specifically at the interaction with drugs. So here, all the interaction terms with all the MRI tasks, all these variables were included in addition to the other variables that were there before. So we see here, it still persists, and I'll show you, and there is an interaction, drug by emotional phases in the ventromedial PFC and amygdala. So here it is, there was an interaction between this increase in ventromedial PFC and amygdala connectivity that was stronger. It was still retained in the Withing model, suggesting that this association was stronger in individuals in the ketamine group compared to the midazolam group, which is flatter. So the greater improvement from pre to post infusions in PTSD symptom severity as measured with the CAPS was associated with greater change, improvement, increase in ventromedial PFC amygdala connectivity. And interestingly, when Dr. Norbury looked at, this is a 7 symptom dimension model of PTSD that goes beyond DSM-5. And what we found is that there were stronger relationships between this improvement in connectivity of the VMPFC and amygdala and the prototypical PTSD symptoms, such as re-experiencing, so the R squared, close to 0.3, close to 0.3, close to 0.3. The other symptoms are smaller, and here there's no correlation, for example, with negative affect, small with anhedonia. So it's these three that are most robustly related to this change. So this one is re-experiencing, avoidance, and anxious arousal. This 7-dimension model separates anxious arousal from dysphoric arousal, and anxious arousal is basically hypervigilance, and the other symptom is increased startle. Further, in addition, this was only observed in the ketamine group and not in the midazolam group. We saw a decrease in abnormal activation of dorsal anterior cingulate activity when this is the contrast of incongruent condition in the face droop task with the congruent condition. So typically in studies of PTSD, we see hyperactivity of the dorsal ACC. And here we saw that with greater improvement on pre-post in PTSD symptoms, there was a decrease in this, what we think is overactivation of the dorsal ACC. And then in the resting state connectivity, there was the higher the improvement from pre-post infusions in PTSD symptom severity, the higher or greater the improvement in ventromedial PFC and anterior insula during resting state. So the results of these, actually, I won't have time to discuss the details of this dynamic causal modeling, but Dr. Norbury further looked at directionality of, was it the amygdala or was it the ventromedial PFC, the main finding? And she found with this DCM approach that really the ketamine group showed greater top-down inhibition of the amygdala by the ventromedial PFC. There was a lessening of the amygdala to ventromedial, so down to top, ventromedial PFC excitation that seemed to be regardless of group, midazolam or ketamine. But greater top-down inhibition was specific to the ketamine group. And this has intriguing parallels to the neural mechanisms implicated in successful extinction learning as conducted by Dr. Daniela Schiller and others, where there might be the same regions and higher activation of the ventromedial PFC is associated with more success in extinction learning. And this is my last slide. So as we've been talking about, ketamine is thought to open, and Dr. Sanakora mentioned, is thought to open a window of increased neuroplasticity. And so a lot of people are very interested also specifically in PTSD, but obviously depression. Dr. Sam Wilkinson would talk about that tomorrow. And recently we heard about this in substance use treatment, adding a trauma-focused therapy to ketamine treatment for PTSD and its potential synergistic effect. And the idea being that there's some evidence from animal studies that ketamine enhances extinction learning. And then also this window of increased neuroplasticity. And we plan to test this idea at Mount Sinai by adding a brief exposure-based therapy to a course of ketamine infusions and to see if this combination can prolong maintenance of, so reduce the relapse of that loss of response over a longer period of time. And we're also going to add a task that was developed by Dr. Norbury, which is an online extinction learning task. And so we're going to see whether an improvement in extinction learning following the first few infusions is associated, can predict longer time to response, longer time before loss of response to ketamine. So I'd like to acknowledge, this was a large team, to acknowledge my mentor, Dennis Charney, with whom I began my studies of ketamine for PTSD, and Agnes Norbury, without whom these analyses would have not been possible, and then Dr. Sarah Costi as well, co-organizing this conference. She was a key contributor to the study when she was at Mount Sinai, and many others. Thank you.
That's wonderful. Thank you so much. Adriana. We look to discussing that later. Keep it in the chat as they occur to you as we carry on. We're going to move straight on, though, to Paul Glue's presentation. Paul has kindly dragged himself out of his bed to talk to us. It's the joys of Zoom what can make these things possible. So Paul is Department Chair and Hazel Buckland Professor in Psychological Medicine at the Dunedin School of Medicine, the University of Otago in New Zealand. And so I think that just without further ado, we'll crack on. Thank you, Paul.
Thank you very much, Rupert and Sarah, again, for organising this meeting. I think it was a real shame last year that it couldn't take place, and the fact you've persevered is just an amazing feat. Next slide, please. I do have a disclosure. I'm working with a pharmaceutical company in New Zealand to develop a controlled release oral ketamine tablet, and I'm named on a number of patents for that. Next slide, please. This is a little bit of a sort of a historical deep dive that it's reporting studies that were originally planned in 2015. And at the time, there were very consistent positive findings that ketamine was working in treatment-resistant depression and bipolar depression from a number of international sites. And there were two additional positive findings in anxiety-related disorders. So Feder's report in PTSD and Carolyn Rodriguez's report in OCD. And our thought was, well, could this be a much broader effect? And we wanted to look at ketamine's effect in generalized anxiety and social anxiety. And there was a rationale in the sense that the brain network activity in depression and anxiety seems to show a lot of similarities, and that there were similar alterations in glutamate signaling. Next slide, please. And the initial plan was to do a three-stage study. We wanted to recruit patients who had treatment-resistant generalized anxiety and or social anxiety, but no current major depression. And again, the thinking behind that was, if people were significantly depressed, the improvement in anxiety symptoms could be an epiphenomenon of the improvement in depression. So that was why we excluded major depression. And in terms of severity, patients had to have a Hamilton anxiety score of 20 or more, or a Leibowitz social anxiety score of 60 or more. And these are well-established cutoffs for at least moderately severe anxiety, generalized with the HAM-A, or social anxiety with the Leibowitz scale. And the initial study was simply to do an open label dose response in 12 patients. And at the end of that study, we had a data safety monitoring board to adjudicate, are you seeing a positive treatment effect? And if we weren't, we would stop at that stage. However, we did see a positive signal, so we then had a second study which used the same dose response but had midazolam inserted randomly in the sequence. So the doses of ketamine that we chose were 0.25, 0.5, and 1 milligram per kilogram given subcutaneously. This was weekly dosing, and the reason we chose the doses that we chose were that in some earlier work that we carried out with Colleen Liu in patients with major depression, 0.25 of ketamine seems to be right at the threshold of response. 0.5 and 1 seem to be reasonably active. And we used a low dose of midazolam as the psychoactive control. And for patients who showed an improvement on either the Hamilton Anxiety Scale or the Fear Questionnaire during the ascending dose phase, we're eligible to go into a maintenance phase where we would continue with either once or twice weekly dosing. We found that about half of the patients needed twice weekly dosing, that the effects wore off relatively quickly, and all patients eventually wound up on 1 milligram per kilogram, and the longest we could dose for was for 3 months. So that those are really our data. Next slide, please. And the assessments that we carried out were vital signs over the first 2 hours. So patients would be sitting in a big comfortable chair for 2 hours after dosing. We looked at dissociation using the CAD scale up to 60 minutes. And we used the Fear Questionnaire and Hamilton Anxiety Scale from pre-dose out to the end of the week post-dose. The Fear Questionnaire was designed by Isaac Marks about 50 years ago, I guess, and it looks at a number of phobic situations. So personally, I think it's much easier to use than the Liebowitz scale for patients with social anxiety symptoms. And during the maintenance study, again, we monitored vital signs out to 2 hours, looked at dissociation, only looked at phobic symptoms and anxiety ratings to 2 hours. And we also looked at I guess, a functionality scale using the work and social adjustment scale. Next slide, please. And in terms of patient disposition, we had patients with predominantly comorbid social anxiety and generalized anxiety in both studies. If one looks at the baseline rating scales, the Hamilton anxiety was 26 to 28 in both of the ascending dose studies. The Liebowitz social anxiety scale was in the high 80s or low 90s, which again is suggestive of extremely high social anxiety, and MADRS scores were quite low. Of the 24 people who completed the ascending dose studies, we enrolled 20 into the maintenance study, of whom 18 completed. Next slide, please. This is the initial 12 patients that we put through, and I'd like to concentrate on the left-hand graph for a moment. This is the phobic anxiety questionnaire, and it's looking at the change in Fear Questionnaire ratings over the 168 hours. And one can see that there's an immediate reduction within 1 to 2 hours in Fear Questionnaire ratings. And there's a dose response. So the the effect of the 1/4 milligram per kilogram is quite fleeting. There's a bigger drop after 0.5 milligrams per kilogram, that's the red line. And the black line, which is the 1 milligram per kilogram, shows the biggest reduction in ratings, and there's a greater durability of response. Middle graph, we're seeing a roughly similar pattern with the Hamilton Anxiety Score. And on the right-hand graph, this is looking at ratings of dissociation. And as we push the dose up, we see greater dissociation ratings that peak at about 30 minutes and are either gone or starting to descend by 60 minutes. Next slide, please. And for the double-blind dose response study, we add in one additional line, which is the midazolam line, which is the green line. And we're seeing, again, very similar trends there, that as we push the dose up, we see a bigger drop initially, that we're seeing an improvement within 1 hour for both the fear questionnaire and Hamilton anxiety scales. The midazolam seems to actually have quite a substantial effect on the Hamilton anxiety ratings. That's the middle graph, but relatively small effects on phobic symptoms in the left-hand graph. And again, these are not surprising findings. And midazolam has no effect on dissociation, whereas the 3 ketamine doses do in the right-hand graph. Next slide, please. We also measured pharmacokinetics in the double-blind cohort of the study, and one can see that both ketamine, which is the left-hand graph, and norketamine concentrations show a dose-related increase. Ketamine levels peak at around 15 minutes and then decline rapidly. Norketamine levels rise more slowly, and again, that's not surprising given the way that ketamine is metabolized. We always see slightly higher concentrations of the R enantiomer compared with the S enantiomer, and again, this has been reported in the literature, and there are some metabolic reasons why this might occur. When we correlated clinical symptoms or clinical responses with the pharmacokinetic data, we see the only correlation was with peak ketamine concentrations and CAD scores. And we reported this in the study that we published with Colleen Liu back in 2016. We also looked at serum and plasma BDNF concentrations, and our hope was that changes in this would provide some peripheral biomarker of what we think might be an important transcriptional change in brain. And it's been very disappointing. With this and with some of the tablet studies we've completed, we've collected a lot of BDNF data, and it really is completely uninformative. So, so long for this being a potential biomarker. Next slide, please. We also looked at dose response. So we took all 24 people who'd completed the ascending dose part of the study and looked at percent change from baseline in 3 different rating scales at 24 hours post-dose. So the fear questionnaire, the red line and red symbols, Hamilton, the black line and black symbols, and we also looked at the Spielberger State Anxiety Scale, and we see that they all show a dose-related greater reduction in scores. These appear to asymptote after 0.5 milligrams per kilogram. And my feeling is that in the same observations from Maurizio Fava, who published on this in patients with treatment-resistant depression. They certainly showed that 0.5 and 1 milligram per kilogram gave a greater improvement in depression ratings compared with lower doses. And we seem to be seeing the same thing here for generalized anxiety and social anxiety. However, it is interesting that on an individual patient basis, that when people went into maintenance, that they all wound up on 1 milligram per kilogram. So I think the idea of dosing at a population level versus an individual level is still a bit of in my mind, an unresolved question. Next slide, please. These are maintenance data. The left-hand graph is looking at fear questionnaire ratings. Right-hand side is Hamilton anxiety ratings. On the vertical axis, there's a gray blob that gives the mean score rating prior to initially getting dosed. And for the fear questionnaire, the red line is the patient's score but before getting dosed, and then the black symbols below that are the scores at 1 hour post-dose. For the fear questionnaire, it appears as though it takes eight weeks or so before we get asymptote. Whereas in the Hamilton anxiety scale, by 2 weeks, patients pre-dose have basically achieved the lowest score that they're going to get. And it's quite possible that for the fear questionnaire, because it has a phobic avoidance element to it, that some measure of exposure is needed. Whereas for the Hamilton anxiety score, it's simply looking at a range of psychological and physical symptoms of anxiety. So that there may be no exposure needed for getting maximal benefit. In functional terms, patients did incredibly well. They got jobs. If they were working, their performance at work improved. They were able to go out on dates. They were able to go unaccompanied to supermarkets. It was quite an extraordinary improvement. And at the end of the study, 25% of patients remained well. We stopped their ketamine, and there was no recurrence of anxiety symptoms. And for those of you who deal with patients with anxiety, these tend to be chronic disorders. So the fact that a quarter of patients did not get recurrence of symptoms, to me, is quite extraordinary. 50% of patients had anxiety come back, but to a much less intense degree. And a quarter of patients got their anxiety symptoms back within a couple of weeks of stopping dosing. Next slide, please. Other observations, and again, this is not part of a randomized trial. We had 5 patients who had comorbid panic disorder, and during both acute and maintenance treatment, their panic symptoms just disappeared. And then finally, a lot of patients had specific phobias, especially blood injury phobia. And one of the subscales of the fear questionnaire looks at ratings of blood injury phobia, and the ratings on the scale decreased. And we've recently finished a study in patients with spider phobia, looking at oral ketamine, and we see a quite remarkable reduction in phobic anxiety when they're exposed to virtual reality spiders. So it may well be that there's a very broad impact of ketamine on anxiety disorders. Next slide, please. So since we started planning and carrying out the study, Jerome Taylor has published his crossover study in social anxiety that showed a positive effect. There's a very nice narrative review by Banov and colleagues looking at ketamine on anxiety disorders and anxiety symptoms in patients with depression. And then we just heard from Dr. Fader, who's I think published some beautiful repeat dose ketamine data in patients with PTSD. Next slide, please. And so just to wrap up, I think we've shown in 2 studies that 0.5 to 1 milligram per kilogram of ketamine has quite consistent rapid onset anxiolytic effects in patients with treatment-resistant generalized anxiety and social anxiety, that we can maintain these effects with maintenance dosing, and again, on an individual basis. Some patients can survive on one dose a week. For others, we need twice weekly dosing. And I think one of the most intriguing findings is that ketamine could have a broad therapeutic role across all anxiety disorders. And for a condition where there's an enormous amount of treatment resistance, this could really revolutionize management of patients. I'd like to acknowledge funding from Health Research Council and James Hume, and I've listed a number of very important collaborators as well. Thank you very much.
Paul, that was fantastic. Thank you very much indeed. Really interesting, really nice and clear. Thank you. So we're going to have a break now, your questions have been captured and will form the sort of first part of the discussions that go on. But I hope that you'll join those discussions and that they're the decent lengths of sessions so that we'll be able to get into the meat of some of these issues. Just to remind you, the talks have been recorded, but the discussion sessions will not be recorded. So you can talk freely. With that in mind, let's aim to reconvene. You should, see the breakout room icons will appear at the bottom, and then you can select which breakout room you wish to go to start with, and then 3/4 of an hour later you can switch over into the other room. So just to remind you, room A will be Carla Canuso and Jerry Sanacora, and room B will be Adriana Feder, Celia Morgan, and Paul Blue. So you've got an opportunity to ask questions and listen to the discussion with the panelists. The panelists will probably get asked similar questions in both sessions, but that's okay. So we look forward to seeing you in about 15 minutes. Okay, thank you.